My name is Gee Mathen. I am from Texas Children's Hospital. I'm Director of Pharmacy for Technology and Finance and Inventory. So one of my areas that we take care of is safety in an interop setting. And we were always faced with the challenge of how to be safer. Pharmacists, how many pharmacists sit in the, everybody? Pharmacists always believe in safety. We always have all kinds of systems, but in reality, if you think about the OR, it's the only location where you have the prescriber, the preparer, and the administrator be all in one, right? And imagine the faults with that, because you think you did it right, you think you've labeled it right, you think you administered right. That is a flaw, and unfortunately, the price that we pay for that is errors that happen to the patients that go completely undetected, because it's self-reported. And the only time we really know about it is when we have a sentinel event, a coded event, or situations that happen. So we want to just jump through how we took safety at the point of administration a completely different way. Next slide. So in 2010, I just remember, this is 2022, about to be 2023, there was a paradigm shift. APSF said, we need to start using barcoding technology and labels in the OR. It's unsafe. But it's 2022, and many hospitals still don't adhere to the standard. We still adhere to, next slide, Glenn, what we used to do. Handwritten labels on a roll. We've seen this in your institutions if you don't have a labeling system. It's pretty common. But there's no room that allows us to have safety. I think you go the other direction without any barcode technology. Next. So safety in a perioperative environment, we worked and we got 10 years ago, we got safe labeling system. It was difficult at first. The anesthesiologist said, well, we don't need this, we have a safe system. But now, 10 years later, anesthesiologists will not allow us to take these systems away, because now it's been proven to be so much more effective and safer for patient care, allows lots of handoffs to happen without problems. Next slide. If you could look at it, the syringe has compliance built right in. So it has the name, 2D barcodes, you know where the preparer was, expiration date and time. If you ever look at many syringes in the anesthesia area, they're handwritten, never do you see a consistent labeling for the name. You can't read it, but definitely finding expiration time and date, almost impossible. So for Joint Commission, we had our last 2 visits, gave it a gold standard. They said the best practice. The physician that rounded in the OR came and said that he's never seen this before, and he's been to 50 or 60 hospitals. So it was very scary to me. It's like, wait, everybody should be using this. We thought this was a more commonplace than not. So hence, I said, hey, we'd love to be able to come and tell people in pharmacy the importance of having a system like this. Next. The best part is that we worked with Codonics, and we move forward in connecting the systems together. So we work with Epic. You can scan the label inside the OR, and it integrates between Epic, Omnicell, and the label printer. So the integration takes away areas of where you have too much work happening, or where you have memorization steps. It's all integrated. So efficiencies are gained, right? And in high volume settings, and efficiency that's safe is a win for the patient. Next slide. We also have started working on documenting what the waste is. You know, diversion is a problem. Anesthesia is a very big place for diversion waste. So we've started working with checking what's actually being wasted at the point of the waste. So that's something that we are really counting on, but that label helps drive that as well. Next. So BCMA for infusions. One of the other things we implemented is if you have the label that's on here and you work with Codonics, you can program your smart pumps with just a scan and 4 clicks. Otherwise, it's 14 clicks on a smart pump in a dark operating room, usually on the floor, or close to the floor. That takes away, once again, from safety. Pump is wrong, you've got that continuous infusion running on a patient incorrectly for a longer period of time. So I want to end with a quote that I really love from Christina Barnes, who's the director of pharmacy at Vida Services, and I won't read it, but it says, first do no harm. If you have the capability to prevent harm, you should do it. The biggest conversation when I talk to other people, my peers across the country, is, well, it's anesthesia's responsibility. I really don't think so. I think it's our responsibility as pharmacy to take care of patients all the way through our system. If you think about it, the cost within our hospitals of a color laser printer, think about it. What do we do with color laser printers? That's all that your investment would be to put this into an OR. And that is safe. If it was you or your children, you would want that safety as well. That would be what my pressing request to you would be.
Safety is important for us. It's a priority. We don't want to be the hospital that has the headlines of a patient had a medication error, a fatal medication error at our institution. But it's more than that. I think as healthcare moves forward, we have to take responsibility that we don't cause harm to our patients. And when you don't have a technology out there, we can sit there and think, well, gosh, it'd be nice if that were available. But now once you know something's available, it becomes your responsibility to make sure that you're not causing harm to your patients. And there was a technology out there that could have prevented that, and you chose not to implement it.